Thank you guys for being here. So I'm going to do some extremely dense, kind of repetitive slides with a bunch of information, but the goal is to get you guys familiar enough, because if you're going to give grand rounds, then you need to speak in those academic terms we use, and you need to know the words, and you need to know a few statistics. And I am going to try to, while I'm talking, give you guys a little bit of kind of how we got where we got, why we framed the survey the way we did, like what led us on that path. The other reason is, like, why are we talking about this? Why did we write a grant? Because there's connections, right? There's connections between physicians' professional struggles, the financialization of healthcare, and the solution, right? Universal healthcare free of profit motives. And so we want to learn how to make those connections, how to make them quick, how to make them in ways that's consistent with like what you would talk about or how you would express something. I will give you a trillion versions in addition to the versions that Carol just gave you of definitions, again, so you can use the ones that feel comfortable to you, that you can frame well, and then I'm going to try to like be sure you can see the references. There's not that many references that are good. There's some references in this list that are bad, but I'm giving two anyway because I think it's helpful to know what's out there. And of course, right, those are the goals for today, but we're here because of the goals for tomorrow and beyond. All right, I'm going to read these to you. Carol mentioned the focus groups, which were just so compelling and moving, and man, you talk about you do something, you need to like have a beer. Like they were all like that, like just intense sessions. So our profession has been taken over, ruined, decimated. We are complicit in a racist system. That's the dirty part. I feel exhausted, helpless, useless. This is unsustainable for me. I'm always pressured to churn. We just have to do more with less. Less time, less support staff, more patients. If a patient wants to talk about anything outside of preventive care, they get unexpectedly billed. Those 3 dots are a whole bunch of sentences I couldn't fit in the box. And I felt like I had to protect a little bit of that focus group internal discussion, but I hide clinical info that isn't preventive care so the patient doesn't get billed. We're employees of a corporate beast. The system exploits the fact that we care. I feel like I'm in an abusive relationship with my employer. Institutions cut resources and staff and then milk docs for more labor. Corporate incentives are destroying the practice of medicine. Profit incentives are so strong that it's literally burning out an entire generation of physicians. The system says we are lacking, when really we are chronically over-functioning. That over-functioning term has just stayed with me. Think of it like when I'm closing my last chart, this is over-functioning me, just getting through the day. All right. So making these connections between moral injury. So that focus group, that bunch of, you really don't need a definition of moral injury now, do you? Right? That is it. Those experiences, those are morally damaging. People who took an oath and came to a profession to help other people and devoted years of life to learning the science and getting the background it would be to take care of them. So I think one thing that we heard all morning, right, was the consequences of society and even our profession accepting the idea that healthcare is a for-profit business, that healthcare is a commodity. And we have to just remember that that's at the basis of a lot of the problems and then a lot of the problems with the solutions that are out there. So thinking about this and helping people make these connections, and again, this is like the super dense slide that I'm just going to work past, but you'll have access to the slide. You can have the pieces you want. You can take out the things you want. And the one thing I'm going to read off this is this concept of conflict of interest. A conflict of interest is a situation in which a person or organization is involved in multiple interests, financial or otherwise, and serving one interest could involve working against another. We find ourselves working against our patients. This is a Google AI-driven definition. Nothing complex, no big thinking. Or maybe it was Wikipedia, actually. I think it was Wikipedia at the bottom there. All right, corporatization. Again, I don't need to define these things for you, right? It's turning our healthcare into corporations. Again, when you're talking to a bunch of people, you got an MBA in your group, it's nice to have the actual definitions handy, or to even rattle them off early so people understand why we use different words. Corporatization meaning this horizontal and vertical integration that's been happening, where we saw that 29% of all Medicare Advantage is one guy and his yacht. Different guy, but I'm sure he's got a yacht. And then privatization, like just thinking about, the publicly funded Medicare, the privatized aspect that is this beast that is Medicare Advantage that we heard so well about today. And then financialization, it's a word that gets thrown around. Literally, it's in the definition of our grant because, RWJF wanted to look at the harms of financialization, both on physicians as well as on perpetuating structural racism, which is an aspect of the study we're doing. But it's, just thinking through these terms, involves transformation of public, private, and corporate healthcare entities into saleable and tradable assets. I'm going to take this healthcare system and sell the real estate that it's on. I'm going to sell the buildings. I'm going to sell the workers. I'm going to sell the ER and the product it creates, right? And then this idea that healthcare entities operate under this shareholder primacy, of course. This article, The Financialization of Health in the United States, it is a short, well-written article, and I don't always put all the gory details in there. I know Ed would be really proud of me because there's all the links, but I kept them in there just so you could easily pull up this, and this is a good one that I would recommend. We don't need to talk about the harms of financialization because we listened all morning, right? And we have access to taking advantage. But again, these quotes come from this excellent article written by a health policy person in Health Affairs, really, really good, just talking about how this goal, the goal being making the most money, led them down this path of fraudulent billing, right? Now, to most of us in the room, that's what? That's not a natural connection. I don't know. If you're in the business of selling stuff, I guess, and making things worth more than they were, it may be a natural outcome. All right, so now we've corporatized our healthcare, we've financialized it, and physician well-being. Now, I'm not going to get too cynical. Well, maybe I will, but I love the way we take terms in medicine and we somehow make them sound better, right? We kind of massage. Anyway, diminished physician well-being, whatever. We started recognizing burnout first. Meanwhile, moral distress was mostly being explored and researched in the nursing literature, kind of in parallel to what we were doing. But again, even within that moral distress literature in nursing, the problem has always been based in individuals, and when they really were thinking big, then they placed it on units and teams, or maybe the hospital, or that hospital system, but nobody started thinking about what about our actual non-system that we practice in. Maybe could there be a problem with that? And it hasn't been researched, and it certainly hasn't been proposed as solutions. I mean, I don't know. I just couldn't resist the chief wellness officer shit, right? Really? That's the solution? A chief wellness officer? And, this Dr. Shanafelt, who I assume is a nice guy, the chief wellness officer from Stanford, we're going to talk about one of his articles. Anyway. So here we are with diminished well-being, October 2024 New England Journal article, actually a relatively good review of burnout. And what's interesting to me is the only place they talked about these things that actually matter was in their very intro. And in their intro, they actually say, number one, there's lots of different ways people talk about this. We talk about it in stressed context. We talk about it in the context of burnout. These authors were kind of wanting to make an argument, I believe, for talking about it in the context of depression, which again I don't think is valid. As I just gave Carol the shivvies. But they literally quote, the article by Wendy Dean, say, excessive workload, administrative burdens, and profit motives of insurance and pharmaceutical companies and health systems are intractable barriers to improving patients' lives in the ways physicians had envisioned. And This is the only place they mention all this stuff, and they never really come back to thinking about it. But again, the other article that's cited there is that Boston Globe article that Wendy Dean and Simon Talbot wrote. I might be reversing his name there. I apologize. Okay, busy, Adam kind of slide. Don't even tell him I said it that way. But you'll notice that 1/3 of it is the references, because I want you to have access to those. And I just want you to notice the purple reference. The title of this article, The Business Case for Investing in Physician Well-Being. Right? Really? We need a business case for like making doctors enjoy their, anyway. So again, I'm just going to say, when you give talks, I don't think we should minimize the impact this has, right? The idea that 300 to 400 physicians a year kill themselves. The idea that physicians are much more effective at killing themselves. Why? Because they're doctors, right? And so the attempt to actual completion rate is higher. The idea that we have rates that are 1.5 to 2.5 times the average population. The idea that 15 to 30% of medical students qualify as having depression. Like, all of this shit should just be lighting a fire under all of us to fix this problem and not recommend yoga or hire a guy from Stanford, right, to fix the problem. Again, Carol mentioned the way burnout is described, and, I've had someone raise their hand and be like, I don't think burnout's as bad as it's supposed to be, because if you define it by one of the, anyway, there's 3 aspects, right? There's 3 aspects: emotional exhaustion, depersonalization, and this lack of sense of personal accomplishment. Most research says about 80% of physicians check one at least of the 3, which in my book is enough for burnout, but whatever. You want to argue about these definitions? Sure. Here's the data. Again, this is from the Office of the Surgeon General, and just note that here, everybody acknowledges it, right? Societal and cultural and healthcare system issues are the factors associated, but nobody thinks to fix those 2 boxes. And that's why we're doing this study. That's why we're sitting in this room together. That's why we're going to do the surveys. That's why we're going to go out and give these talks, because we have to start talking about fixing those other 2 boxes. These are just slides for you guys. This is from the Medscape 2024 study. They do it every year, but it's data on the percentage of people who describe themselves as burnt out or depressed. These are other interesting slides. Again, style-wise, you can choose how you want to talk about it. I love this from our classic, Single Payer 101 talk, the idea that we spend twice as much time on the electronic billing record as we do with patients. And then this is my other favorite. I'm sorry, it's animated. I'm never good at animation. Oops. But this is because we're so prolific and we just like to write when we take notes. No, this is because we have an electronic billing record as opposed to the rest of the world. So Carol mentioned the concept of moral injury, and it comes from the military. This is if you're giving a talk to a group of psychiatrists or other people who are going to kind of push you on the definitions, it's good to know where it comes from. And within the PTSD world, people sort of figured out there were actually people who had something really different than what PTSD was. And there was these 3 requirements that Dr. Shea thought of: the betrayal of what somebody thought was morally right, the betrayal coming someone from who was in legitimate authority, i.e. maybe our department chair, being in a high-stakes situation, maybe life and death, maybe pain and suffering, high-stakes situation. So these are how this got carried over to us, but again, characterized by those feelings of powerlessness, helplessness, guilt, and shame. This is another way to define it that comes from PTSD. I've used this slide more than the last slide because I don't find the military context always that helpful, and it has fewer words on the slide, which seems like it's good, but again, you can kind of use what you need. My favorite way of describing moral injury, though, does come from Wendy Dean and her book, and she repeats this over and over. Moral injury is this sense that clinicians know what their patients need, and I love, even in her quote, and she's extremely articulate, but she switches from they to we. They cannot get it for them because of constraints outside of their control. And what this does is it causes us to wonder whether we can be the doctors we thought we could be. We made a promise to society that we would heal and that we would put our patients before all else. And yet, as soon as we go into practice, we realize that there are so many barriers in the way between what we know we should do and what we're able to do. I love that. Again, these two slides are for the purpose of you're giving a talk. You need the definitions. Why do we sometimes call it moral distress? Why do we sometimes call it moral injury? In the nursing literature, it's described as this continuum, centered around the inherent integrity of our profession, and then looking at this as moral distress as being where we see repeated episodes of moral distress contributing to this moral injury. And some writers will talk a lot about potentially morally injurious events. Like any other thing in medicine, it's all caught up in its words and its language, and we like defining shit over and over. But, again, you can imagine what that is, right? An event like Sarah described to us of having a 5-year-old in front of her with a curable cancer who gets stuck in the hospital that they may be made bankrupt or in debt for life over curing, right? That's not potentially, let's just call it a morally injurious event. I'm not going to take a lot of time, but this idea of physician autonomy, again, I have a Google AI definition here that just sounds so wonderful. I wish I lived in the world of Google AI. That is not practicing medicine these days, right? It's sort of based on this idea of we went into this business to kind of be our own boss. We would be guided by our oath to our patients. We would be guided by science and medical guidelines. And obviously that is not what dictates the care we provide. However you look at it, whether it's insurers, whether it's our hospital systems, and how they're tied to our system. And again, I think this issue of, I say this all the time, the sanctity of the patient-physician relationship, but that is complete and utter bullshit, and it is a fallacy, and it's the same as the fantasy that we heard about earlier, right? There is not really such a thing in healthcare anymore because, insurers have, of course, access to all this information. My patient gets diagnosed with cancer and she needs a little time off work. Oh my God, they have every note. They get anyway. But then again, we come back to the really basic idea of the trust in the relationship is based on the idea that we put our patients' needs first and that our system will respect our need to put our patients' needs first, right? That's that conflict of interest problem that we're in. And this is an AMA definition, also quite lovely. I wish the AMA would deal in reality. I'm just going to real quick, somebody brought up already this OBGYN, right? But it is just a case study in eliminating sanctity of a relationship, eliminating physician autonomy in any way, right? The idea that we have government-mandated conversations that include misinformation, right? Somebody comes to me and I need to tell her, well, having this abortion is going to increase your risk of breast cancer, which is completely and utterly false, right? But that's written down by some legislator who doesn't even know what a fallopian tube is, right? And they're telling us this is how you take care of a miscarriage. Well, I don't think that's life-threatening. We need her to be a little sicker because we will only do an abortion in the setting of the mother's life is threatened, and I'm not feeling threat yet. The fear of litigation, loss of license. I have several slides if you all are interested in this whole discussion around criminalization and carceral care and how medical information is used in our legal system to put pregnant women in jail, and why that might lead that pregnant woman to not have an honest conversation with her doctor, right? Oh, shocking. And why that doctor might be uncomfortable having the conversation or writing notes, or if there's a third person in the room listening to the conversation. The complexities of where we've let our system go, right? The complexities of how somebody at Stanford is the one writing the articles who's making money because he's helping other people develop wellness programs for their hospitals, and he's a separate business other than his being the chief wellness officer. And I don't know him personally, and he's probably a really nice guy, and whatever. I should let that go, but that business case got right under my skin. All right, so I spent a couple painful weekends reviewing the literature on moral distress and injury and surveys and trying to figure out, like, how do we measure it? How do we do this? And there really actually are no tools that measure the connection between big system, this is the whole country's non-system, and how that process influences moral injury. The best group out there studying this was a group at Virginia Tech, and they at least sort of had done the 2 steps up from some of the burnout and other studies where they were looking at hospital systems, they were looking at slightly bigger levels, and they were willing to work with us so we could take their validated tool, alter it, and that's how we kind of used their scales and other things because that was the validated part of it. And we added more questions, and we'll see. And the really exciting thing to me about this survey is it's going to evolve. We're going to look at what we get back, we're going to look at the comments we get back, and we're going to keep evolving that tool. And hopefully, as long as we need to continue the conversation between moral injury and the financialization of our health system, we will continue to get that data and put it out there. The ultimate goal of this research is to help us, not only help our colleagues, but help them see why the answer to their problems is universal health care free of profit-driven conflicts of interest, right? Help them make those connections, help them draw the things that we sort of don't think about. And again, use this slide set, use the data, use the handing out the survey, however feels right to you, right? If it just allows you to talk to people who would never dream of some lefty business like PNHP, but are interested in research and are interested in the profession of medicine and are invested in us keeping our profession, well, we're not asking them to join, we're not even asking for money, although we'll take it if they want to give it to us, but we're not. All we're asking them to do is participate in the research. And Carol mentioned, we're gathering these surveys, but the real meat of our study is going to be interviews. And so we're hoping, in those surveys, to gather up people who are willing to do a 60 to 90-minute interview where we get narratives, where we get people who are willing to talk about what they've been through, talk about these stories,